Okay, so I think without any further ado, we'll get started. Thank you everyone for joining us this morning. Um, Before I introduce our renowned speaker, I wanted to review some quick logistics and housekeeping. Um, just a reminder to log in and out of the call or restart your computer if you're having any problems. That's usually the first recourse if you're having any challenges hearing or seeing the presentation. Also, during the webinar, feel free to type in if you need any support. I'll try to help you as much as I can. Also, please keep your sound on mute during the webinar because this will minimize any interference and enable a smooth webinar. Also, you can do that by right-clicking on your microphone icon that is next to your name, and it has an option to mute or unmute. So please take a moment to do that. Also, if your microphone or the icons next to your name are gray and not blue, that might mean you might have some problems with your audio. So again, please log in and out or restart your computer. And also using headphones can optimize the sound. So without any further ado, I'd like to introduce our webinar, which is part of the UNICEF collaborative, which really tries to synthesize and collate a lot of the emergent evidence regarding HIV as it relates to children and adolescents. And we are really honored to have today Dr. Lynn Moffinson, who for many of us needs no introduction. But regardless, I would like to mention that she is a pediatrician and infectious disease specialist. She has worked and spent most of her career conducting research on the prevention and treatment of pediatric and maternal HIV infection in the U.S. and globally. She is most known for a lot of her work at the National Institutes of Health based in the U.S. Currently, she is a senior HIV technical advisor for the Elizabeth Glaser Pediatric AIDS Foundation, where she focuses on implementation science research on pediatric and maternal HIV treatment in Africa. We have been honored to have Dr. Moffinson as a presenter on our webinar series for several years in a row, and she is here to give us a very thorough and rich summary of the abstracts and research presented recently in CROI 2018 that are related to pediatric, adolescent, and maternal HIV. So without any further delay, I'll turn it over to Lynn to give us her summary. So, Lynn, over to you. I think I apologize. It looks like Dr. Moffinson might be having some problems, so logging in again. So if you give us a moment while we work that out, I'd appreciate it. In the meantime, if you can write in and let us know where you're calling from, that would be great. Hi, everyone. Thank you for your patience. We're just waiting for Lynn to log in again. Again, apologize.
Jessica, can you hear me?
Yes, we can.
Oh my goodness.
Yes.
Okay.
Okay, I introduced you, so
Okay.
and also, as to avoid maybe any more loss of connection, feel free to start. I introduced you, and we're very happy and honored to have you here presenting.
I need to get back onto the.
Yes, as a presenter. Okay,
yeah.
Give me a second.
I don't know why the linkage is doing this.
Sure. Okay.
All right. Well, I will go ahead and start and hope that this doesn't happen again. Sure. Hi, everybody. I'm going to give you some selected presentations from CROI related to pediatrics, and I'm going to start with the PMTCT cascade. So this first study was an evaluation of the cost effectiveness of repeat testing during late pregnancy in Kenya, and they compared two strategies, a strategy of no retesting to a strategy of retesting. And you can see if you compare the total costs to the quality-adjusted life years saved, that repeat testing had an incremental cost-effectiveness ratio of $1,098 per QALY. And cost-effectiveness in the Kenyan setting is 1,367. So this was highly cost-effective to do repeat testing. And when they looked at a hypothetical cohort of 100,000 women, they found that you could prevent 504 infant infections antepartum, 253 less postpartum by breastfeeding, giving you a 93% excess infection if you did not retest. It also decreased mortality, 173 deaths among mothers, 30 less in children. The excess cost of repeat testing was only $16, and the cost per infant infection averted or maternal infant death was very reasonable. So they concluded this was a highly effective thing to do. The next study comes from South Africa, and it's looking at postpartum mobility and transfer of care. And they used electronic health data to access HIV care access and mobility in pregnant women who were starting treatment in Cape Town. And they saw that these women, they were required to transfer to the HIV clinic postpartum as opposed to continuing to receive their drugs in the antenatal type of setting. And they access care at 98 different facilities. And looking at the women, you can see that 21% of the women never linked to care. Oh, we have music.
Please place your mics on mute. You can do this by right-clicking on your microphone. Thank you.
Okay. So as I said, of these women, of these 617 women, 21% never linked to care. Of the 485 who did link, 21% attended 2 or more clinics. Of the 485 who linked, 90% of these women access care at 12 months, 82% at 20 to 24 months. Those are the purple boxes. 75% at both time points, but that is only 59% of all women. I'm just going to talk through this, guys. Of the retained women who had viral load available, 87% had viral suppression. But when you look at the entire group of 617 women, that was only 49% of all women. And they found that younger age and unemployment were risk factors for multiple steps in the cascade. The next study looked at text messaging for retention in PMTCT. They had 2 phases here. The first phase was a randomized trial where they randomized 10 facilities to text messaging, 10 facilities to control, and then phase 2 was a step wedge implementation in 20 facilities. They used 14 different types of text messages tailored for specific points during pregnancy and the postpartum period. And unfortunately, text messaging by itself had a small and not statistically significant effect on both infant testing. It was 91% with the text messaging, 85% without, or maternal retention, 90 versus 76%. And they noted that they were going to look at more of a combination prevention intervention in the future. Moving to pregnancy outcome. These are data from Botswana. They abstract data from maternity records, over 75,000 maternity records between 2008 and 2016, including antenatal HIV and syphilis test results. 27% were HIV positive, 1% had a positive RPR, and co-infection with HIV and syphilis was present in 37%. And they found that HIV and syphilis was significantly associated with both stillbirth, almost a twofold increased risk. You can see 5.8% rate of stillbirth with HIV and syphilis compared to 1.9% without HIV and syphilis, and also with low birth weight. This study is the Zambia Preterm Birth Prevention Study, or ZAPS, and they are enrolling both HIV positive and HIV negative women. 929 have given birth. 23% of their cohort is HIV positive. Most of this cohort is on treatment. 56% were on preconception treatment, and most of the treatment was with a tenofovir efavirenz-based regimen. Of the 929 deliveries, they had 16% SGA, 2% stillborn, and 14% preterm, which was their target of interest. And the factors associated with preterm delivery: prior preterm delivery is no surprise, twin gestation, also no surprise, short cervix, no surprise. But they also found, even in a sensitivity analysis, that preconception treatment was also associated with preterm delivery, and other studies have also shown this. Luckily, preconception treatment was not associated with very preterm delivery, so this increased risk appears to be between 37 and 34 weeks, so earlier preterm delivery. This is data from a hospital-based birth surveillance program at 4 hospitals in Kampala, Uganda, kind of like the Botswana data, where they're looking at data reported for all births. This data includes 43,000 births, 11% of the cohort, over 4,600 were HIV positive women, most on treatment and most receiving efavirenz-based treatment. Here we go. They had 475 birth defects, 1.1% and 0.9% in the HIV exposed and unexposed. So the prevalence was similar between HIV positive and HIV negative women. That's very reassuring. And even when you looked at birth defects that were of concern for efavirenz, such as neural tube defect and cleft lip palate, there was no difference. Additionally, when they looked at preconception versus during pregnancy start or first trimester treatment versus second or third trimester treatment, the prevalence of birth defects were similar. So this was very reassuring regarding birth defects with efavirenz-based treatment. Moving to talk about pregnancy and antiretroviral drugs. The first study I wanted to touch on is the National Study of HIV in Pregnancy, and this comes from the UK. And raltegravir was used in 709 of over 10,000 reported pregnancies to HIV positive women, so this was 7%, and increased over time from 0.5% to 14.4% in the most recent years. Use at conception also increased from 15% to 30% in the most recent years. And the birth defect, there were 6 pregnancies with stillbirth, 728 live-born infants, and the rate of birth defects was 3.1% in the raltegravir exposed infants, and this is very similar to the general population. Additionally, there was no difference between first trimester versus second and third trimester, and no specific pattern of defects, so very reassuring data for raltegravir. There was a separate study that was actually at the meeting just preceding CROI, the Women in HIV meeting, that I thought was important to look at. And this was a PK study of darunavir and cobicistat in 6 pregnant women, and they evaluated them antepartum as well as postpartum. So the antepartum is in the blue lines. The light line, I think, is third trimester. The dark line is second trimester. And the orange line is in postpartum. And you can see that there was a significant decrease in darunavir exposure when given with cobicistat, more than was seen when given with ritonavir. And this was a significant decrease to over 80 to 90% decrease in trough levels and 40 to 50% decrease in peak levels. And viral suppression was seen in only 83%, suggesting that some caution needs to be used when this combination is used in pregnancy, and that if you use this, you should do careful viral load monitoring. And the last one is the Dolphin study. This is an open-label randomized trial of dolutegravir versus efavirenz-based treatment in women presenting late to antenatal clinic at 28 to 36 weeks gestation in Kampala and Cape Town. And this is based on an interim analysis of the first 16 enrolled, with the primary endpoints being pharmacokinetics and safety. And you can see there was no difference in adverse effects between the dolutegravir and efavirenz arm. There was a modest decrease in dolutegravir levels in the third trimester, but not enough to warrant a dose increase. And they noted that they had problems with adherence for both regimens. The dolutegravir regimen had a more rapid decrease in viral load, but in the end, there was 2 viral failures in the dolutegravir arm and 3 in the efavirenz arm. So this was not necessarily related to the virologic efficacy of the regimens, but rather to the women taking the drugs. This is data looking at the administration of the vaginal contraceptive ring with either efavirenz or atazanavir-based treatment. So they looked at levels of estrogen and progesterone administered via the ring in women receiving no treatment, efavirenz-based treatment, or atazanavir-based treatment. And when they looked at estrogen exposure, you can see that in the red line compared to the green line, which was the control group, there was over a 50% decrease with efavirenz and about a 30% decrease with atazanavir in blue. And then when they looked at progesterone type exposure, significant decrease, almost 80% with efavirenz, but an increase with atazanavir ritonavir. And they concluded that atazanavir ritonavir was unlikely to affect contraceptive efficacy, but efavirenz had significant enough decreases in these hormone levels that it certainly could affect contraceptive efficacy of the vaginal contraceptive ring. This is a study that looked at pregnancy and bone mineral density in B+ in Uganda. So we know that pregnancy and breastfeeding are associated with physiological decreases in bone mineral density, but there's been minimal data about HIV-positive women. So they did DEXAs to assess bone mineral density, and they also looked at bone turnover markers at 36 weeks gestation and postpartum 2 and 14 weeks in breastfeeding women who were HIV positive receiving tenofovir-based treatment and HIV negative, with the primary comparison being the postpartum changes. And in terms of bone mineral density, they saw a decrease in bone mineral density in both HIV positive and HIV negative women, but that the hip bone mineral density decrease was greater in HIV positive than HIV negative women. And again, there was an increase in markers of bone turnover in both HIV positive and HIV negatives, but these were greater in HIV positive than HIV negative women. And we really need to see data about what happens after the women stop breastfeeding. Normally, bone mineral density rebounds back up, and we need to see whether there is still a decrease in HIV positive women. This is a separate study that looked at a similar thing. It's looking at bone mineral density in the context of a clinical trial of tenofovir to prevent hepatitis B virus transmission. So this is not HIV positive women. This is women with hepatitis B, and they were randomized to third trimester tenofovir versus placebo. And they looked at maternal and infant bone mineral density 12 months after delivery. And they found no significant difference here in maternal hip or lumbar spine bone mineral density or infant lumbar spine bone mineral density at 12 months postpartum. So these are mothers who stopped treatment, so their bone mineral density came back by 10 months after stopping treatment, and the infants who were not being exposed had normal bone mineral density, so this is very reassuring. Moving to testing, treatment, and retention for children and adolescents. The first study comes from Lesotho, and this is a nationally representative sample of children under 15. They did household-based rapid testing and looked for HIV prevalence. They tested almost 4,000 with an overall HIV prevalence in children of 2.1%. And when you look at age, you see that this is highest among the 10 to 14-year-olds, 3.2%, lowest in the 0 to 4-year-olds, 1.0%, suggesting that we have good PMT-CT working in Lesotho. Corresponds to over 13,000 children living with HIV in the country. There was an imbalance, more females than males, and this imbalance may be related to sexual activity. The 10 to 14-year-old increase is related to sexual activity, and 15% of boys reported being sexually active between 10 to 14 years of age. That's a lot. And it varied significantly across the districts, and doing this kind of population-based study where you can actually look at prevalence in different areas can help you to target your interventions more appropriately. There were two studies that looked at lopinavir-ritonavir. The first study is Impact P1106, which is a phase 4 study looking at antiretroviral drugs in low and normal birth weight neonates and young infants. And they reported on dosing of lopinavir-ritonavir 300 to 75 milligrams BID, and found reassuringly that the levels in these low birth weight infants and SGA infants at this dosing were similar to that in adults. And you can see in adults here is the black line, the median for the infants, the newborns is the green line, and the red line indicates the trough level that you want to keep people above of 1 microgram per ml, and you can see that that level was achieved in all of the infants regardless of birth weight SGA, and there were no treatment-related AEs. The second study was a single-arm open-label study of lopinavir-ritonavir pellets in young infants. They had 610 children who could not swallow tablets. 522 were antiretroviral experienced. Most of these were switching from the lopinavir liquid. 38 were failing nevirapine and switching to the pellets, and 58 were naive. The study was done in Kenya and Uganda. And you can see that the baseline and 48-week viral load that was available for 220 children showed a significant decrease in viral load and good viral efficacy both in experienced and naive patients. AEs were relatively uncommon, and only 2 led to treatment discontinuation, suggesting that the pellets are a very good solution for kids who can't take tablets to move them from the horrible tasting liquid to something that's easier for them to take. Looking at HIV-TB co-infection in children, P1110 was a study of raltegravir given as a chewable raltegravir tablet, 12 milligrams per kilogram per dose, given twice a day with rifampin in 12 infected children between 2 and 6. And they found that doubling the raltegravir dose in patients with TB on rifampin allowed you to reach appropriate raltegravir PK levels. And as you can see from the graph, that there was a good viral response. The second study was a cluster randomized trial in 16 clinics in South Africa comparing the conduct of household child contact evaluations, either using symptom-based screening or a TST-based screening, with an endpoint being the percent of children identified and started on IPT. And you can see there was really no difference between the symptom-based screening and the TST-based screening, so it was not inferior but not better to do symptom-based screening. And the main message, I think, from this study was that entrance into and retention into the pediatric TB preventive cascade was bad regardless of how you were doing screening, and in the end only 9% of estimated contacts completed IPT. So we clearly need to do better with tuberculosis preventive therapy in children. There were a number of presentations that were very interesting on early treatment and viral remission. The first study I thought was important because it deals, I think, with our ability to diagnose HIV in exposed infants. And this study evaluated maternal viral load and pretreatment viral load in 91 infants with in utero HIV infection in a universal birth testing program. Some of these mothers had not received treatment. Most of the mothers were on treatment. And you can see from the graph that the infant viral loads was significantly lower when the mother reported being on treatment and successful treatment, with maternal viral load less than 1,000. So for mothers who reported no maternal treatment, the infected infant viral load when they were diagnosed was 48,905. If they had any maternal treatment, but the mother's viral load was over 1,000, the median level in the infected infant at diagnosis was 35,000. But in mothers who were on treatment and had good suppression, if they had an infected infant, the median viral load was only 801. So that suggests that we may have some trouble in diagnosing those infants. And when they looked at infants who had a low diagnostic viral load, so a viral load of over 1,000, 55.6% had mothers on treatment compared to 13.7%. And so you can see that maternal pre-treatment viral load was significantly correlated with maternal viral load when the mother was on treatment, but not when the mother was not on treatment. So when the mother was not on treatment, she had a high viral load, and the infant viral load was high regardless. But when the mother was on treatment, if her viral load was low, the infant's viral load was also low. And that suggests that it may be more difficult to diagnose infection in those infants who are born to mothers on treatment who appear to have successful treatment. The next study was looking at the evaluation of the reservoir in a longitudinal cohort, HivNat 209, and these are children who are receiving free drug antiretroviral prophylaxis. So they're born, they're HIV exposed, they get 3 drugs, and that could either be given continuously, so the child was on 3 drugs, diagnosed as HIV, started on treatment right away without any break in treatment, or was on 3-drug prophylaxis, which was stopped. The child was diagnosed with HIV a few days or weeks later, and then treatment was started again. And they also had a cohort of children, a cross-sectional cohort of children who started treatment at less than 6 months, but not at birth, that they could compare viral load to. And this group had a median age of 5.1 year. And they then looked at measures of the reservoir, total DNA, integrated DNA, and the inducible reservoir. And if you compared children before treatment was started, in all children, baseline viral load strongly correlated with the reservoir, total and integrated DNA, as well as the frequency of productively infected cells. When they compared children who had interrupted prophylaxis and then started treatment, compared to those who had continuous prophylaxis and treatment, there was significantly lower viral load, number of cells with integrated DNA, and the size of the inducible reservoir. If you looked at these children after they started treatment, you could see decreases in total and integrated DNA when they started treatment, but this remained detectable in almost all of the children. And integrated DNA was stable after 1 to 4.7 years on treatment. So it decreased, but then it stabilized. The age at treatment start correlated with the reservoir, and it was lowest with the youngest start, and in the cross-sectional study, infants starting treatment at age less than 6 weeks had the lowest reservoir. And then comparing children who had the continuous prophylaxis going to treatment to those children who started treatment at less than 6 months but hadn't started at birth, the continuous group had a significantly lower viral load, a significantly lower integrated and total DNA, and a trend towards a lower inducible reservoir. So again, the earlier you start treatment, the better you are. This is a study from Botswana, the early infant treatment study that is looking at diagnosing HIV in newborns and starting treatment within the first year of life. They have enrolled 33 children and are reporting on 9 with complete testing for this report. In the 9 with 84-week data reported on treatment, you can see there was a significant decrease in cell-associated DNA on treatment. At entry, it was 154 copies per million PBMC. At 84 weeks, this decreased to 5.3 copies per million PBMCs, and this is actually lower than in most other early antiretroviral treatment cohorts. And most of these were defective. In the children with complete testing, we're going now to these 9 kids again. Whoops, I'm pushing the wrong thing here. Okay, so this looks at the viral load in these children over time through 84 weeks. And you can see in the orange boxes that 4 of the kids, 44%, did have an RNA blip to over 40 at 1 or more visits. Most of these suppressed with improved adherence. You can see in green that 8 children had viral load less than 40 at 84 weeks, and it was 6 at 96 weeks. And 6 of the children had a negative DNA PCR. 5 of the children had a negative antibody test. And all 4 children who had consistently suppressed viral load also had a negative DNA and negative ENA and EIA, and the authors suggested that having a negative DNA PCR and a negative antibody may be markers of a very low reservoir. This is the SHARE study, and they were looking at the time to viral rebound after starting treatment. And just to remind you about the SHARE study, they enrolled antiretroviral naive infants aged 6 to 12 weeks, normal CD4, and they were randomized to either deferred treatment, early time-limited treatment for 40 weeks, or early time-limited treatment for 96 weeks. So we're now focusing on these early time-limited children. They had RNA from stored specimens measured at 8 weeks post-interruption and then every 12 weeks. So they were able to look at these children who were successfully suppressed on treatment, stopped, and then looked at whether they stayed suppressed, whether they rebound, and the time to rebound. And you can see 86% of the children had suppressed within 40 weeks. But almost all of them, 96%, had viral rebound after starting treatment, with a median time to rebound of 1.8 months. And this shows you the probability of rebound. By 2 months, 70% had rebounded. By 4 months, 80%. 6 months, 94%. By 8 months, almost all of them had rebound. And when they looked at what was associated with rebound in a multivariate model, they found higher baseline CD4, higher birth weight, and more rapid viral suppression was associated with a longer time to rebound. They did not find that age to starting treatment, now remember all these kids started at 6 to 12 weeks, so they all started early, or that duration of treatment affected the time to rebound. Now I want to move and talk a little bit about some studies that talked about adolescents and HIV risk. So this first study is the Zambia Population-Based HIV Impact Assessment Survey, a cross-sectional household survey in 2016, found that HIV prevalence was 3 times higher among young women than young men, 15 to 24, 5.7 versus 1.8%. And the study examined demographic, behavioral, and biologic factors associated with HIV in young women reporting sexual partners. And overall prevalence in these young women was 7.8%. And this shows you the factors that were associated with HIV prevalence, but more importantly, on multivariate analysis, the 3 things that were associated with HIV prevalence in these young women were age 20 to 24, urban residence, and past or recent syphilis infection. This is data from HPTN 068. This was a study that evaluated the effects of monthly cash transfer to improve school attendance and prevent HIV in South African girls. This study had a negative results, but this was a secondary analysis of about 1,000 HIV uninfected girls who had reported a baseline sexual partner. They did annual Acassi self-interviews and HIV testing and had 63 incident infections among these 1,000 girls for a rate of 6%. So when they looked at self-identified up on the top there, partner, whether the partner was regular or not regular, but they also were able to use the Acassi to look at a latent analysis, which basically looked at and identified 6 distinct sexual partner types that differed by age, school enrollment, concurrency, condom use, transactional sex, etc. And they found that this analysis, this latent analysis, was able to identify 2 types of partners that were associated with incident infection, older partners, and also peer-age partners with unprotected sex. And I don't think either one of these is extremely surprising. This is a study from Botswana that is looking at baseline self-report sexual behavior in over 2,300 sexually active youth. And girls reported that they had HIV diagnosed prior to the survey in 20% versus 4% in boys. And There were differences in risk behaviors between girls and boys. Economic stress in girls and food insecurity was strongly associated with risky behavior in the girls and intergenerational sex. And when they did a multivariate analysis to look at what was associated with HIV status in the girls, it was significantly associated with intergenerational sex. And in the boys, it was associated with earlier sexual debut. Moving to talk about PrEP. This is a study that looked at PrEP in pregnant women. It looked at over 5,000 HIV uninfected women at 16 antenatal clinics in Kenya, screened them all for behavioral risk factors. They found that 16% of women accepted PrEP, and then when they looked at the behavioral risk factors, they found very reassuringly that those women who were more likely at risk of HIV were those who were more likely to accept PrEP. For example, there was an increased acceptance of PrEP if there was condomless sex, prior diagnosis of STI, and most reassuringly that almost all of the women who reported that their sexual partner was HIV positive accepted PrEP. Reasons for not initiating PrEP were that mostly that they knew that their partner was HIV negative, but not because they were afraid about using PrEP or had fears of for their unborn baby, and that was reassuring in terms of pregnant women being accepting of PrEP. This looked at reasons for PrEP acceptance in young women in a study that is looking at offering PrEP to young women 16 to 25. They can accept or decline at enrollment, and it is an ongoing study. And in this study, they found very high acceptance of PrEP, 95% uptake, despite the fact that they reported low perceived risk. Even though they reported low perceived risk, the risk behavior was actually relatively high, with a high incidence of sexually transmitted diseases and a high incidence of depression and reported intimate partner violence. So good acceptance of PrEP in these young women. This looked at patterns of oral PrEP acceptance among in an open-label PrEP demonstration project, and they looked at different types of adherence and different types of risk. And they identified 4 different types of adherence trajectories, either those who had adherence that started good and declined rapidly, adherence that started good and declined later, those that had moderate steady adherence and high steady adherence, and 2 types of risk trajectories, one where their risk declined over time and the other one where they had steady risk. And they found that risk and adherence groups were significantly associated, that the steady risk group was more likely to have high steady adherence, so that's pretty good that women who knew they were at risk adhered to PrEP, and the declining risk group was more likely to have declining adherence. So this suggests that these young women are able to identify when they are at risk and to adhere to PrEP. There were 2 studies of extension of the dapivirine ring studies. So the first study was the Aspire, and if you remember, this enrolled women, randomized them to the dapivirine ring or a placebo ring, and had in their initial study showed a 27% reduction in the risk of infection. They had a 1-year open label extension. 92% of the women used the open label ring. They had very good adherence. Almost 90% had levels in the ring that indicated they were adherents, and they had 12 incident infections. The sister study, the ring study, also randomized women to the dapivirine ring versus placebo ring, had 31% reduction in infection in the overall study, had a 1-year open label extension called the DREAM study. Again, they had very good adherence, had 11 infections. So the initial trial results of both of these studies were similar, 27 and 31% efficacy, and the one-year follow-up incidence was also very similar. And if you compare this to an estimated placebo group level of infection compared to the incidence in the extension studies, you can see that both of the studies had a significant decrease in HIV incidence that was basically the same, 46% decrease with HOPE, 54% decrease with DREAM. So these data are very reassuring that these are true findings and that when the ring is being used in an open label fashion, it has reasonably good adherence and efficacy. Moving to issues related to maternal health. This was an important study, I think. This looked at HIV acquisition and risk per coital act. So this is two studies looking at two HIV prevention studies in over almost 2,800 HIV negative serodiscordant couples. And in these studies, they had frequent testing for HIV and pregnancy, and also they collected data monthly on sexual act frequency and condom use. They found that the frequency of sex actually became lower in late pregnancy and postpartum, and that condomless sex was higher in early pregnancy. They had 78 incident infections, and they characterized study time as early pregnancy, first trimester, later pregnancy after 14 weeks, up to 6 months postpartum, or non-pregnant. So adjusting for condom use, age of the woman, PrEP use, male partner, viral load, when you look at non-pregnant versus pregnant and postpartum, you can see a significant increase per coital act in incidence of HIV, 1.05 versus 2.91, which is an adjusted relative risk of 2.76. And interestingly, when they looked at it by these different categories, early, late, pregnancy and postpartum, there was not a significant increase in early pregnancy, but there was a significant increase in late pregnancy, and interestingly enough, highest in that early postpartum period, with a 3- to 4-fold increased adjusted risk. So pregnancy and the early postpartum period are a very high risk time for HIV negative women. These are data, the PROMISE study presented data from multiple pieces of PROMISE. So this is looking at the maternal health component of the PROMISE study. And you can see in the box we're looking at, in the PROMISE study, women with CD4 over 350 are randomized to antepartum treatment with 3 drugs or AZT single-dose nevirapine. They're randomized postpartum to maternal treatment versus infant nevirapine. And after they stop breastfeeding, they're randomized to continue treatment or stop treatment. And that is what this analysis focused on, those women who continued or stopped. Primary question was, what is the effect of extending treatment after breastfeeding cessation? They had very low rates of AIDS and death, an incidence of 0.23% in both arms. AE were more common in the continue arm, but still relatively low. And in those who had another pregnancy and were either on ART preconception or not, there was no difference in outcomes. This study then looked at a more prolonged view. So here we're comparing women who were randomized to treatment antepartum, and then they were randomized to 3-drug treatment during postpartum and continuing, versus those who then stopped treatment, that went on infant nevirapine and received no treatment afterwards. And they also looked at the study 1077HS that was done in high-resource countries where they didn't have breastfeeding and they just either continued or stopped treatment. So women who discontinued treatment had persistently lower CD4 than those who continued, no surprise, but none of them went below the 350 threshold. Time to WHO stage 4 or death was low in both groups, whether they continued or stopped, although I think that there were more deaths in the discontinue than continue group, and I think that these deaths were more related to HIV, so there's a hint here that continuing is better. And when they compared outcomes between the breastfeeding study in blue, 1077BF, to the formula feeding study in orange, HS, they were very similar. So being in a low resource setting and a high resource setting didn't make a difference in terms of AIDS events, death, or safety. But what I wanted to point out is that in both breastfeeding and non-breastfeeding settings, continuing treatment was superior to stopping treatment in terms of having recurrent WHO 2 or 3 events. So while AIDS and death were infrequent, these events were not as infrequent, and continuing treatment was beneficial. This study then focused, another PROMISE study, looking at what happens to those women who discontinue treatment, either after delivery or after breastfeeding, what happens in terms of time to rebound. They found that the median time to rebound after stopping treatment was 2 weeks. And in terms of staying suppressed, only 11% were suppressed at 8 weeks, and only 6% suppressed at 24 weeks. So 94% of these women rebounded within 6 months of discontinuing treatment. And now this study then looks at a different piece. It looks at those women who continue treatment and asks what happens to them. Do they rebound or do they stay suppressed? And the probability of viral failure was actually, unfortunately, relatively high. Using a threshold of greater than 400, 29% had rebounded by 144 weeks. And South America and Caribbean versus Africa had the highest rate of estimated viral failure, and predictors included reporting missing a dose, younger age, shorter duration of pre-entry treatment, and region, and only 50% of these women resuppressed. This is data from the APREA Apprise study. This is an important study. It was looking at the safety of giving INH preventive therapy given during pregnancy, or whether you can wait till the postpartum period. They took 956 pregnant women, and they were then randomized to immediate prophylaxis with INH during pregnancy between 14 and 34 weeks. And after completing that, they went on placebo versus deferred INH prophylaxis, where they started on placebo, and then at 12 weeks postpartum, they received INH. So both groups got INH, but it depended on when they started, either during pregnancy or postpartum, and they were followed up for 48 weeks, with the primary endpoints being maternal safety, infant safety, and here we go with, there was no significant difference in maternal safety endpoints by study arm. And this includes hepatic toxicity. Interestingly enough, that if you look at the graph with the lines, both groups went up in terms of ALT and SGPT postpartum, but there was not a difference between those who started during pregnancy or started after pregnancy. So there was no difference in hepatic toxicity. There were 6 maternal deaths. 4 of these maternal deaths were due to hepatitis. 2 of these hepatitis events were related to INH. 1 occurred in the immediate group, 1 occurred in the deferred group. The other 2 hepatitis were not related to INH at all because the women had not started them. But overall, there were more adverse pregnancy outcomes in the immediate during pregnancy IPT arm. So there were 926 deliveries, and if you look at any adverse outcome, it was more common when they started INH during pregnancy, 23%, versus waiting to postpartum, 17%. So they concluded that there was no significant difference in maternal safety profile, maternal hepatotoxicity, infant adverse events, or maternal infant death. There were low TB rates in both mothers and infants in both deferred and immediate arms. So in the treatment era, TB is relatively rare. But IPT during pregnancy appeared associated with higher risk of overall adverse pregnancy outcomes. And they concluded that deferring IPT until the postpartum period appeared safe and did not result in excess TB cases, while immediate IPT during pregnancy may be associated with adverse pregnancy outcome, and recommended that IPT in women be postponed until the postpartum period. And I think, Jessica, I'm going to stop there rather than going on because I know we want to leave some time for questions.
Okay, great. Thank you so much, Lynn. We'll open it up for questions to the audience. If you have any questions on clarification or how this has implications for programs, please feel free to either unmute your mic or type in the question and we'll read it out loud. So any questions or comments from the audience?
Well, while people are typing in, there we go. Okay.
Hi.
Hi.
Hello. Yes. Who's speaking?
Chewe.
Hi, Chewe. I'm sorry I didn't recognize your voice.
No, I just wanted to ask on this. I think it's Lesotho study that looked at prevalence in children. Is that correct, Lynn?
Yes.
Yeah. And the high prevalence that you start to see from age 10, which might indicate sexual exposure, and then the finding that boys are having sex very early. I think that's what you said, right?
Yes, that's right.
Was the prevalence data disaggregated by sex?
Yes, in the prevalence. Let me go back to that slide. It's like. Let me try to find it to look at it. Okay, so the prevalence 10 to 14 was 3.1% in males and 3.3% in females. So actually, in that age group with the sexual activity, the males went up. So for 0 to 4, it was 0.6% in males. From 5 to 9, it was 0.9% in males, but jumped up to 3.1% in males, which kind of goes along with the sexual transmission, with 15% of the boys reporting sexual activity in the 10 to 14-year-old age group.
You know, this is so important, and I'm sure my colleagues that are looking at the data on adolescents would agree with me, because we always talk about the heightened vulnerability in girls and the fact that the sexual debut is younger in girls. And from our spectrum models, we talk about, the increased incidence in girls compared to boys. And so the focus in a country like Lesotho has been what we do with the girls. But this data is actually indicating that we have to equally work hard to do something for boys, and that we might be seeing some incident infections quite early in boys compared to what we think that it's much later. So the implications
I agree with you, because there was another study that they presented where HIV incidence was associated with earlier sexual debut in boys. Right. So I think those two studies are consistent.
Thank you.
Thank you, Cherry and Lynn. We have a question that was submitted by someone. Their name is a guest, so I'm not sure who it is, but it's regarding the study on preterm delivery. With the findings on preterm and low birth weight, how did those with HIV compare with the general populations, and were those comparisons shared?
I'm wondering which study that they're referring to.
I think it was in the beginning about preterm delivery.
Yeah, there were several talking about that. I don't. I think that this was a poster, and I don't recall them comparing this to the general population, if I'm remembering correctly. This is the ZAP study, I think, that they're talking about. But I would have to go back to the abstract, but my memory is that they didn't compare that to the general population.
Okay. Great. Thank you for clarifying. So any other questions, comments, clarifications for Lynn?
Just a comment for people that you can go online to CROI, and on all of the slides I list the abstract number, and you can pull up the abstract and look at the full abstract as well. And the other comment is that there is a more comprehensive slide set that has a little bit more details on some of these, as well as a number of other studies that UNICEF will also be making available on their website that accompanies this.
Okay, great. So I don't see any more questions or comments. And like Lynn said, we will have this abbreviated slide set as well as a full version, which is about 100 slides with all of the most pertinent science shared at CROI available on our website, as well as the recording to the webinar. So if you missed anything or want to share the webinar with your colleagues, which we highly encourage you to do, it will be available following the webinar. And as always, you can contact myself or Lynn if you have any follow-up questions. I want to extend our heartfelt appreciation to Dr. Moffinson for giving us such a thorough overview of all of the latest research shared at CROI, and hopefully it inspires us to see how this research can translate into practice on the ground. So thank you very much, and we hope to see you at our next webinar next month.
Okay, bye-bye.
Thank you so much, Lynn.
All right, bye.
Okay, bye-bye.
Thank you, Lynn.